And if you want to start the webinar and let me know when we're live. Okay. Just let me know. Okay. Well, good afternoon, everybody. Thanks so much for coming to this last HRI seminar series of the year. We are very proud to present the 2022 honor student who have a space now to present on their health research work over the last year. My name is Leanna Garway. I'm the manager of the Health Research Institute. We just want to take a moment to acknowledge that this seminar series is sponsored by a variety of people: School of Health Sciences, Nursing, Social Work, the Northern Medical Program, the Psychology Program, and lastly, a Sun Life Financial Endowment Grant. If anybody would like to contact me and or are interested in presenting at the seminar series, please go ahead and email me. We also record all of these seminar series. So if you're interested in checking out any of the other ones, please go to our website. We have several years of presentations recorded on there. Today, as I mentioned, we have the honor student presentations. And then this is our last seminar series for the year. We're going to resume in September 22, and that will be every third Thursday of the month after that. I am going to turn it over now to Margot Parks.
Wonderful. Well, I'm greeting you all from here on a different part of Platelet Tenay territory. I'm sorry I'm not able to be there in person, but in the spirit of health and research, I didn't want to be concerned about spreading cold and flu symptoms around our our talent. So I'm sorry to not be there in person, but I'm pleased. This is a big feature moment for us. And I want to thank each and every one of these honours students, first of all, for choosing to do their degree at UNBC here, making deepening their experiences on Platelet Tenay territory, or moving here from other places and homes and other territories. And I want to acknowledge all of the things and the people, the families, the places, the communities, the landscapes that have underpinned your approach to your degree at UNBC and your decision to do your honours. So we are honouring you through this special session as our honours students. And we're really, this is a big moment for us every year. And I know that there are faculty in the audience as well who have got to know our students through their taking courses with them or meeting them along the way. And we really want to underscore just what a nice moment it is to see when you get to share with us the journey that you've been on. So the process for today is that we're going to move through the presenters in the order that we have here on the screen. And that in doing so, that means that we've got a presentation from each presenter. We're also going to, I think, because we want to make sure that we move through the presentations, we're just going to move through them pretty much back to back. What we'd really encourage you to do is to be putting questions in the chat box for people online, and we will come around and hope to have presentations, a moment for questions and following up with the different presenters. And what that will also mean is that it would probably be good if the presenters were able to stick around the front of the stage for the people in the room. But for those of you that are not in the room, you'll see those chat coming up, and others might be able to start to see the chat as well and how they might be preparing for responding to some questions. It's quite a lot to fit in our time, so we're going to hope that we can make sure that everybody fits in during the course of it. But I think, Leanna, have we got Lindsay able to come up to the front of the stage? That's great. So Lindsay, we're expecting you're the first up, which is a big role, but we're also expecting, it's really nice if we can understand and hear from you who your supervisor is on campus. Probably most of you will have that on your slides, but there we go. There's an example of it. So Lindsay, thanks very much for your contribution. And
hello, everyone. I'm excited to share my research with you today. My topic is on asexuality. So for those not in the know, that is a sexual orientation for people who do not experience sexual attraction. Now, as you can imagine, this interacts with healthcare in various ways. Because this is an emerging field, there's all sorts of recommendations from researchers saying where to go next. So what my research does was ask the asexual population where they think research in this field should go. And my supervisor is the lovely Dr. Caroline Sanders. To start off, we have a bit of a brain teaser for you. True or false? How many of these things do you think people in the asexual community can do? Take a few moments to answer in your head. And the answer is, they're all true, every single one of them. Now, they might not be true for any individual asexual person, but within the community, there is nothing that precludes someone from being able to do any of these things. And I swear I can hear someone in the room thinking, what about the last one? Didn't you just say people who are asexual do not experience sexual attraction? That is the dictionary definition. But keep in mind, the human experience is a spectrum. There are people between what we would consider to be socially acceptable levels of sexual attraction and complete absence, who might feel that their experience is also described as asexual. This just does justice to the wide diversity that exists in the asexual community. Now, as I stated earlier, this field is very emergent, so any findings would need to be corroborated by future studies. But what we've found so far is that there's some evidence of possible mental health disparities in the community, such as anxiety disorders and suicidality. There's also some evidence of sex normative bias in healthcare. Now, healthcare experiences are quite a mixture of positive and negative, but we do see instances of incredulity, patients not being believed, pressure to have sex, and incorrect diagnoses such as depression or a low sex drive disorder based solely on sexual disinterest. That does not fit the patient. Experiences like these contribute to stress and kind of deteriorate the patient-provider relationship. Of course, researchers have given their 2 cents on where this area should go next, and these were the findings of my literature review. Researchers felt that health concerns, disparities, that sort of topic should be investigated further, particularly in reference to how social factors and practitioner conduct can contribute to stress. There were a lot of recommendations that had to do with educating practitioners. What do they need to learn and what should they unlearn? Just basic population characteristics came up as well, just learning more about the community in terms of identity, romance, sex, things like that. And finally, how do we improve care for this population? Some suggestions have included creating a welcoming environment that makes people feel safe to come out, and finding ways to help with that stigma, that life stress. Now, what my study aimed to do was compare those literature recommendations that you just saw to those proposed by people from the asexual community. As a second aim, we wanted to see what the interest was like in the community in regards to patient-oriented research, because this methodology has not been used yet with this community in this topic, and it would be a strong way to make findings more relevant to that community. So we wanted to see if there was interest. To conduct the study, I recruited 4 participants from AVEN, that's an asexuality forum, and we went through semi-structured interviews about 30 to 60 minutes, where people were asked about their healthcare experiences and research recommendations. Then I transcribed the audio and performed an undergraduate student's best attempt at a reflexive thematic analysis. This process involved taking those transcripts and coding different segments as one thing or another, like disclosure or pain. And then taking those codes and creating themes that together seem to explain the full data set. When I did this, I ended up with 5 themes, but for the purposes of time, we will focus just on the first 3 that were the most relevant to healthcare. Take a look at this word cloud. What jumps out at you? This came from words that participants actually used to describe their healthcare experiences. And you'll notice that it is quite a mixture of positives and negatives. You see dismissed and uncomfortable jumping out, but there's also understood and validated that were fairly prevalent as well. So really cannot be categorized as either positive or negative. It is a mixture of both. The first theme had to do with the types of harm that were encountered in healthcare spaces, and we did see evidence of some practitioners having that bias that you need to be having sex to be normal. For example, Maeve was told, well, you could be pregnant and not know it. Maeve is a virgin. These are pseudonyms. Aurora was told, low libido at your age is a problem. But Aurora didn't think it was a problem. Aurora wanted them to get back to the topic of endometriosis, what she had originally come in for. And oddly, don't you want to wait to see if you can meet someone? This was the response when she went to seek fertility treatment to become a single mother. Other examples of harm included sexual pressure, forced pregnancy testing, and there was one instance of a violently painful pelvic examination. And experiences like these, in some cases, actually motivated healthcare avoidance. So participants were telling me, because this happened, I feel more hesitant to go seek healthcare. And as we know, this is a dangerous situation to be in, to feel like you are better off not seeking care in some cases. We also found that harms intersected with other identity characteristics, such as age, biological sex, or geographic location. Participants had a harder time finding an open-minded practitioner in a small, heteronormative rural location. Now, participants did not just sit there and take this, they figured out strategies to circumvent these kinds of harms. Some prominent examples included negotiating disclosure, figuring out when and how to come out. There were examples of self-advocacy, such as Aurora saying, hey, I'm a neuroscientist. My life is together. I deserve to be listened to. Now, obviously, not everyone has the privilege of being able to say, I'm a neuroscientist, but this was a tool at Aurora's disposal and she used it. And finally, participants educated their practitioners about asexuality, not just for their own sake, but to help future asexual patients that would come along. Now, participant testimony gave us a picture of better care, and this picture came from both positive experiences that actually happened, such as being believed and accepted, or encountering intake forms that actually had asexuality listed as one of the options that you could check off. There were also suggested improvements, such as practitioner education. Emerson exemplifies this when they said, they just need to know that asexual people exist and that they aren't broken. And finally, there were suggestions for practitioners to help raise awareness about asexuality. So some stated that had they learned about their identity earlier in life, that would have helped them, and practitioners could play a role in raising visibility so that people could learn earlier. Now, the last 2 themes I have here combined, and these had to do with what it's like to be asexual in day-to-day life and how that impacts health. We found that stigma contributed to stress. These sorts of experiences included identity confusion, social judgment, and there were some instances of sexual violence by one participant. So the asexual population is also at risk for those things. However, life generally improved after learning about asexuality. There was clarity. They were able to accept themselves, and they had the asexual community as social support. For Emerson, the social support literally saved their life as they were battling multiple mental health issues. Just a small number of the research recommendations given by participants included gaining more about the state of knowledge among practitioners regarding asexuality. What do they know? How many people are aware of it? There was a question of how should we approach these sorts of conversations in healthcare without pathologizing anybody? And finally, how often do asexual patients encounter discrimination? And what does it look like? Finally, there was unanimous support for patient-oriented research. All 4 participants were willing to get involved in some capacity. So once again, we ask where to go next, this time informed by what the asexual community has told us. It would seem relevant to develop a basic working knowledge of asexuality among practitioners. Now, so far, this seems to mostly be delivered by patients in the care setting. But participants suggested perhaps self-education. Practitioners could find resources on the internet to learn more about asexuality. And I also wanted to propose to you, imagine what it would look like to have asexuality in high school sex education class. What would that look like? Because I had participants tell me, if I had learned about this when I was in high school, I could have avoided all these negative experiences. And I have another participant tell me, if people in general just knew what asexuality was, my practitioner and I would be able to speak the same language about this. Now, high school serves as a common point for the general public. So public education is a good consideration. We also found that there's merit in increasing the research involvement of asexual people in general. In this sample alone, we found a very diverse population, and that was just 4 people. In conclusion, seeking healthcare as an asexual person is a mixed experience. It is neither bleak nor perfect, and there is room for improvement. Similarly, living an asexual lifestyle is also a mixed experience. While there were some stressful experiences that contributed to health risks, there was also a strong community. And finally, asexual people can get involved in research, and not just me, not just white privileged undergraduate students, but many voices within the community. Thanks for watching. So Margot, tell me, are we doing questions at the end?
Yeah, so what we're going to do is we are going to do most questions at the end, but we are in the form of a sort of a conference format where we have presentations back to back, but we are going to let supervisors pop up and share some initial responses just as we transition the slides. So I'm going to turn the microphone over to Caroline, and then I'm going to take a hand up from Jessie that I see probably with another query about the process. So Caroline, over to you. Caroline's online, and we're going to give her the power to speak.
Thank you. Can you hear me there? Is that okay, guys?
Yes, we can.
Super. Lindsay, congratulations. Well done. I know that you have worked so hard and tirelessly since last May, well before we even started your honours project officially, to be able to do the work that was needed in this area. I am thrilled that you have been a pleasure to work with, and your presentation today did you proud with the data that you have managed to collect. I am keen for us to continue to work and publish this because it's a very important area that is very highly neglected, as we've discussed. And I just wanted to really give you a well done in a public space, because I know I say that to you, but it's nice for everybody else to hear it as well. Congratulations and well done.
Thank you so much. Could not have done it without you.
Wonderful. Well, congratulations. That was a great start to our presentations today. And I think we're now going to we're going to take the questions later, where and we're going to get people to put into the chat box their questions and we'll come back to them, making sure that we've got time to hear from everybody. So Jessie, I see that your hand was up. Can I hand over to you if you've got a query or a question? It might be a legacy hand or an explanation of needing to step in and out. So we'll come back to Jessie a little bit later. Oh no, no hand up. Okay, there's just a hand there. A high five, we'll call that. Just a big high five to all the presenters. So now I'm going to I'm just going over to the next. Well, we'll just do it like this. This is great. So we've got Aiden Winkle who's doing this next presentation, and we're really happy that we've got some of our students today. Many of them are Bachelor of Health Sciences students doing their honours, and we've also got students coming from, in this case, coming from business. So Aiden, your supervisors are Erin Wilson and Kathui Manu, with a real mix of health and other themes. So we're really looking forward to your 10-minute presentation.
Thank you. Thank you. Can you guys hear me? All good. Awesome.
We can.
So my name is Aiden. I'm graduating with a Bachelor's of Commerce in Marketing. And that's my background. I'm really excited to be presenting my honors thesis, which is titled The Development of an Automated Aid for Health Communication Professionals. Let's get into it. So a little bit of background on what I've been up to for the past year. So this project was actually done in conjunction with a partnership with Northern Health through a MyTax grant. And what that grant proposed to do was to improve the effectiveness of Northern Health's written health communications. And the reason we wanted to do this, because there's been a recent push for patients want increased agency over their healthcare decisions. We're seeing people want to take initiative and have their own healthcare needs met through their own decision-making processes. And that's really been pushed through with COVID-19, as we've seen with an increase in e-health. That's problematic considering across various health domains, from ophthalmology to oncology, there's been reported low readability, actionability, and understandability of health communication materials. Furthermore, there's a genuine lack of tools that can be used to simplify patient education materials, so pamphlets, leaflets, posters, things like that. As well, to our knowledge, there's been no integration of information systems or computer systems to improve these patient education materials. So for that reason, we have the goal of designing, creating, and testing an information system which can be used to effectively create written health communications for populations with limited health literacy. As you can see in the corner, that makes up about 60% of the Canadian population. So this brings me to my research question, which is essentially asking what best practices exist in health literacy literature, which can be applied to the creation of an information system used to make effective written health documents. So a little bit of background, what is health literacy? In short, health literacy is really hard to define. It's an interdisciplinary concept. I like to think of it as people using health information to improve their individual health outcomes across their life course. There is a definition on the board over there, Canadian Public Health Association. This definition is just one of many. As I said, if you Google health literacy, a plethora of definitions comes up. So some of the impacts of low health literacy. The first is in conjunction with a lack of effective written health communications. People rely on unaccredited resources such as Wikipedia to get their health information. This is problematic because when people don't understand, they go to the internet, and that isn't necessarily the best place to find information. Furthermore, low health literacy is responsible for increased hospital readmissions, increased emergency room visits, and increased patient non-adherence, all of which negatively impact patient outcomes. Finally, it doesn't just impact individuals. Low health literacy and a lack of written health communications which are effective increases spending, and it can account for up to 3 to 5% of total healthcare expenditure, which is millions and millions of dollars. So an integration of an information system. We were unable to find any studies which looked at particularly at health literacy and information systems, but we were able to find some studies which looked at the integration of information systems and literacy guidelines. So one study looked at 39 literacy guidelines. They had health experts look at the guidelines and check them by hand for web pages. And then they did the same thing with algorithms and computer software. And what they actually found was given specific recommendations, algorithms and computer software can check for literacy guidelines better than health communication experts. So that's a really promising finding that can support this project. So this leads me to my search strategy. So we conducted a exploratory literary review, which looked at 3 databases, centralized health literacy, and search terms included health literacy, health communications, or patient education, readability, actionability, and understandability, or best practice and assessment or evaluation. It should be noted that readability, actionability, and understandability all come from previous tools, such as the patient education material assessment tool, or Tempted, which is another tool that is generally used to assess health communications for effectiveness. Lastly, we also conducted a search of the gray literature. We did this because often guidelines are published by, for instance, the Center for Disease Control, and won't necessarily be in academic articles. So we looked through the gray literature as well. Yeah, inclusion, exclusion criteria. We wanted articles which were published in English, which focused primarily on written health communications. So there's verbal communication, all sorts of different best practices there, but we only wanted written health communications. Thirdly, we wanted to focus on papers which centralize best practices for the improvement of health communications. Keyword there is improvement. Lots of studies looked and said, these are not effective. These are really bad health communications, but we only included studies which provided tangible guidelines for their improvement. And as well, we wanted studies which were relevant to a Canadian context. Articles were excluded if they were outside of the purview of health authorities or looked at specific demographics with specific communications needs. So that's people who have visual impairments, live with aphasia, have experienced strokes, things like that, as well as immigrant populations or English second language populations. Yeah, and we went from 771 articles to 31 included articles. So the literature analysis came up with 5 main themes or categories of best practices: readability, layout, visual aids, numeracy, and reader engagement. The numbers on the side there are how many of the 31 articles addressed each of the guidelines. So getting into it, readability was our biggest category, and almost all of the papers discussed some sort of readability. This can be broken down into 3 subcategories: reading level, language, and grammar. Reading level is essentially the grade level that's required to understand the documents. So generally this is measured from 5th grade to an 8th grade reading level. There was some discrepancies in this, but that's the grade level that is generally required to digest the information in health documents. Interestingly, one study found that oncological health documents were at about a 10th grade reading level across Canada, so nowhere near the recommended. Language, so this is how the words you're choosing and what they look like. It's really related to reading level and grade level. One study found that if you include sentences which have less than 15 words, you can actually reduce the grade level of health documents by 1.5 grades. Lastly, grammar. So it's not only the words you're choosing, but also how you initiate conversations with readers. So we found that best practices include using an active voice and having conversationist language. That includes using contractions and second person. So some major problems with this category was specificity. A lot of the included literature discussed making sentences short or use common and everyday words, but then left it at that, never included what that means. There was no real bar which could be used or parameters which could be used. Secondly, consistency was a big problem. Some of the literature highlighted really important things that never came up again in any of the included articles. Layout and design. So this again can be broken down into 3 subcategories: aesthetics, format, and text. Aesthetics is everything you see when you first look at a health communication. So that's things like white space, how much of the document is covered by text and visual aid. We found that typically in the literature is 40 to 50%. However, some studies went as low as 10% of white space. That's the same for justifying the left margin and spacing. Going into format, this is related to the aesthetic, but it's how the information is presented. So we found that for documents to be effective, they must include bulleted points. And there was a range of specificity. Some articles said how to use the bullet points, some just said use bullet points. Obviously, we're looking for more specificity there, but we did find that paragraphs which had more than 7 items should be broken down into bulleted lists. Lastly, text, the smallest component of layout. It's really important that we are using fonts which are readable, and those have been identified as serif fonts, so Times New Roman and Helvetica. They have the little lines on the bottom, as you can see in the H's. They have the lines across the top, which makes them slightly more readable. Yeah, once again, specificity and consistency were major problems in this category. Simple fonts, use white space, uncluttered format. Those are all words that can be taken differently. For some people, uncluttered space means having only a little bit of white space. For others, it's no images, but we really need to define what that means so they can be applied to best practices. And then once again, consistency. So last three categories were numeracy, visual aids, and reader engagement. Numeracy, the guidelines were a lot more homogeneous. There's less included articles. So it was a lot easier to identify best practices. Essentially, numeracy guidelines are you cannot trust patients to understand numbers. When presented, they can only be in their simplest form, which is outlined as simple natural frequencies or absolute frequencies. So increasing from 10 to 20 is not an increase of 200%. It's an increase from 10 to 20. Visual aids, same thing. You can't trust audiences or readers to understand what pictures mean. They need to have included captions, and they need to be used for a purpose, not simply aesthetics. Reader engagement, we discussed that having people be integrated into their own decision-making process is important, and we should be outlining this in health documents. So having blank spaces, asking them to fulfill checklists or write down answers to questions, or having frequently asked questions. Yeah. So conclusion. So while we did identify specific guidelines which could be applied to the creation of an information system, lots of the articles provided vague statements which cannot really be applied to the creation of an IS system, nor the creation of consistent written health communications, which is a big problem. Furthermore, while some resources emphasized guidelines which were deemed important, they then were not seen in any of the other 771 articles. So it was really hard to tell what was important within the guidelines. There's tons and tons of guidelines, but a lack of consistency and specificity. Lastly, there was only one Canadian resource which offered best practices. This is problematic as Canada has its own healthcare system, own healthcare needs, and yeah, own health literacy. So limitations, health literacy is not the same as general literacy. We likely missed guidelines which were involved in media studies or marketing or general literacy, anything like that. Secondly, subjectivity and cultural relevance. So we couldn't look at things due to technological limitations such as emotion of document or the cultural relevance of documents. That's not to say they're not important, but it's just to say we couldn't quite look at them yet. So that's something to look at in the future. So future directions, this project, so these guidelines that I've identified are actually going to be used in support of the creation of an information system. With Northern Health, they've been given to a master's student, and that's going to be part of his project. We're going to be talking with Northern Health, and I have here on the slides, useful tech applications require user input. It's really important that we get input from health communications experts who are going to be using this tool, because if it doesn't work for them, it's not useful, right? That's the same idea with the guidelines. They need to be applicable in a real sense. Yeah, and that's everything. Questions?
Great. Wow, you and Lindsay have set a high bar for these honours presentations. Congratulations, Aiden. I'm really glad that we've got Kafui Monu on the line as well. So we're going to upgrade Kafui to be a panelist so that he can also share a couple of words. But yeah, also really neat to see this excellent use of the MITEX funding to do the work. So I'm sure that this is a great example for others to follow. So Kafui, can we let you turn on your microphone? I'm really glad to see that there's questions coming into the chat box, which are going to be great for us to return to at the end of all of the presenters. So over to you, Kafui, just to say a couple of remarks as Aiden's supervisor or one of his supervisors.
Right. Yeah, so thank you very much and for giving me this opportunity to once again congratulate Aiden on an excellent piece of work. And as he mentioned, this is something we'll be incorporating into an actual information system. So this is the sort of thing we need to do our work. And I know you put a lot of work into this and back and forth trying to figure out like the 3 different disciplines that you need to worry about, like marketing, information systems, healthcare. We'll throw computer science in there for an extra 4. But yeah, this is very well done. And we'll see how much impact this can create. And I'm very happy that you were the one to start this great project.
Mhm. Yeah, wonderful. And it's so neat when there's these opportunities, both of these presentations creating the basis for future work. So the next, we are going to keep moving through, hoping we can have a bit of room for questions at the end, but I'm really glad to invite up our next speaker who's going to be presenting online. So Hayley Hervey is going to be presenting. We'll have to get Hayley to test her microphone and make sure that you can share your screen okay. Hayley's going to be presenting on methods of pain management in rural Canada. That looks very promising. That's great. And Hayley, do you want to turn on your microphone?
Yes, for sure. Are you guys able to see that okay?
We can see that and hear you very well.
Perfect. Okay. So, 1 second. Okay, there we go. Hello, everyone. My name is Hayley Hervey, and I'm graduating with my bachelor's in biomedical studies this semester. And I'm excited to share my findings of my honors thesis. Before jumping in, I just would like to acknowledge that I live, work, and am presenting from the traditional unceded territory of the Lheidli T'enneh. And under the supervision of Dr. Klassen Ross, I conducted a scoping review looking at the methods of pain management that are utilized within rural Canada. So as many of us know, rural and remote populations often experience disparities in receiving healthcare, especially when it's for complex and long-term health issues. I grew up in a small community outside of Prince George, and these experiences have driven my passion for the field of healthcare in these populations. And a big motivator for completing this research was my personal experience. After an injury in 2017, I struggled with pain and functional limitations for years. And 1 year after my injury, I was referred to the pain clinic in Prince George. I was on the wait list there for 2 years before I was admitted. During that time, I was able to gain short-term relief through physiotherapy, massage therapy, and various other treatments through my family physicians. But this reality is not the same for those living in rural and remote communities. Typically, that wait would be a lot longer, and those short-term relief strategies are often not available. So before getting started, I would like to define a few terms that will be used throughout the presentation. First, pain refers to an unpleasant sensory and emotional experience associated with or resembling that of actual or potential tissue damage. But an important aspect in pain management is the subjectivity of pain. Pain is always a personal experience that's influenced by varying degrees of biological, psychological, and social factors. And when pain is persisting beyond the apparent biological value and normal tissue healing time, which is most often assumed to be 3 months, it's referred to as chronic pain. And in terms of geographical location, the Government of Canada considers a community as rural if the community has a population of less than 1,000 people or a density of less than 400 people per square kilometer. And remote is often used when a community is located over 350 kilometers from the nearest service center. Despite advances in healthcare system delivery, such as the use of telemedicine, significant gaps are still felt by many. So a scoping review was performed to determine the current state of pain management within these populations. The first step in performing this scoping review was to determine search terms that would be comprehensive enough to identify all of the previous research that's relevant to the study goals. So these search terms were divided into location, different substances that were most often used to manage pain, and different descriptions of pain. After developing these search terms, a list of criteria was set to regulate which resources would be relevant to the study. And in terms of literature type, only research articles published after the year 2000 were included. And this review focused on adult populations strictly. So after completing those searches, I found 221 research articles that were screened by their abstract and title, of which 150 of those were excluded. From there, full context analysis was conducted on the remaining 70 articles, And after that screening step, 18 remained. The articles excluded at this step were removed if they were not relatable to a rural or remote context, or if a newer version investigating that same theme was included and was therefore not as relevant. And also studies were included if they did not investigate a relationship that was applicable to the review. So after analyzing the current state of pain management, a few common themes were found. First of those is the current best practices in pain management, as persistent pain has a wide variety of negative impacts on physical, psychological, and social functioning. A team of various health professionals is often best suited to treat pain conditions. When the resources are available, the typical golden standard of care delivery often occurs through multidisciplinary treatment facilities, of which typically employ physiotherapists, psychotherapists, nurses, social workers, and occupational therapists. And in terms of treating the pain, the previous gold standard was through the prescription of opioids, but with the efforts made to reduce the prescribing of opioids, many practitioners have been left with questions of how to better care for their patients. And while self-management of pain can be undertaken by individuals who do have access to care, those without sufficient access often utilize riskier self-management strategies to fill that gap. So the characteristics associated with the populations who tend to self-manage their pain was an important component to investigate. Recent Canadian studies have found that in populations who use drugs within Vancouver, a major factor leading individuals to self-manage was due to the refusal of prescription pain medications and limited access to safe and non-judgmental healthcare. And homelessness was also found to be a major reason for physicians to be wary of prescribing pain medications, and this was often due to the concern of these substances being diverted and sold in order to make money, and then further contributing to the opioid crisis and other issues. A study conducted in 2020 found that individuals who use substances to manage their pain reported negative experiences with their healthcare professionals, influenced by the cultural stereotypes of them just being drug seekers and the concerns of drug dependence that most physicians are faced with. So with this knowledge, similar factors are likely to be experienced in rural populations, but no literature was found specifically identifying the motivators of self-management in rural and remote populations of Canada. So research investigating the ways in which pain is self-managed was fairly consistent throughout the review. A study conducted in Vancouver again on the self-management of pain among people who inject drugs determined that 52.7% of their study population utilized heroin to minimize their pain, and 65% used diverted prescription pain medications to obtain their relief. Within this same population, a small amount of individuals utilized complementary methods to manage their pain, which included heat, exercise, rest, and relaxation. But a method that is becoming increasingly utilized to manage pain is the use of medical cannabis. A study conducted in 2019 on therapeutic cannabis users within Canada found that 58.3% of their study population reported primary symptoms of their motivations for using cannabis as chronic pain. This study also found that cannabis use was being utilized in the substitution of opioid use, with 59.3% of their study population who previously used opioids reporting total cessation of opioid use. So in rural contexts, multidisciplinary care facilities are often still inaccessible for the majority. In 2020, 91.3% of identified facilities were concentrated in large urban areas, with no facilities in Prince Edward Island or in New Brunswick. And there was an average wait time, in the territories. Nationwide, the lowest observed wait time was observed in Ontario, which is about a month and a half, and in New Brunswick was an average of about 23.3 months. As rural and remote communities do not have access to these services readily, their care falls onto the family physicians within their community. And while this following study is not specific to rural and remote communities, the findings appear to be relevant in the context. So this study conducted was an ethnography of chronic pain management in primary care, which highlighted the roles of physicians in their chronic pain management. The key findings were that physicians' struggles were complicated by concerns that they may lose their licenses for inappropriate prescribing, which many physicians in the study reported that this factor led them to police their patients on drug abuse rather than providing treatment and care that was needed. And multiple family physicians also stated that saying no to their patients was an important aspect of clinical work, but many explained their difficulty in saying no to prescribing opioids when their patients continue to struggle without alternative effective treatments. And this situation can be further complicated for physicians who are providing care in rural and remote communities, which are often quite close-knit. They're active in the community and have relationships with those in the community. Saying no when their neighbor or their friend is in pain can be quite difficult. One physician further stated that, "I think most docs who don't want to prescribe don't want to because it's a ton of work managing someone on opioids, and it's really challenging to get them off. But we don't have the support for that, and it takes a huge amount of time. It would take a huge amount of my time, and I didn't go into med school to become a babysitter." This physician's statements that he didn't go into medical school to become a babysitter further highlight how the work physicians are being asked to perform when prescribing opioids creates an unattainable workload for many, especially in regards to rural and remote communities where there is few other practitioners and physician caseloads are large and quite diverse. These perceptions highlighted by the physicians and the current findings in pain management strategies indicate a great need for the improved delivery of pain management in all of Canada, but specifically in the context of rural and remote communities. Further research should look into the experiences and strategies of pain management specific to rural and remote Canadians, as there was a significant gap in the literature. And this can also be helpful in identifying ways in which services can be improved. And I'd just like to give a huge thank you to Dr. Claassen-Ross for supervising my honors thesis, and Trina Fife for her help throughout the research process, and just the Health Research Institute for allowing us to showcase our research this year. Here are my references, and if anyone has any questions.
Thanks so much, Hayley. Congratulations. It's yet another excellent presentation, well timed, and I can see Tammy sitting there offering some remarks as a supervisor. So I'll hand over to you, Tammy.
Thank you, Margot. I just wanted to say, Hayley, it's been great working with you this year. Definitely showed a lot of flexibility when our first run at this project, didn't work and we had to switch it up sort of last minute. So way to go. Great presentation. And I do look forward to hopefully extending this research maybe a little further and actually doing the project we initially hoped to do. So a good job.
Thanks.
Yeah, well done, Hayley. And it's, as I mentioned earlier, one of the nice things about these honours presentations is meeting people in your class, and then you get to find out about them in with their honours hat on. So that was a really great glimpse into the other work you've been progressing, Hayley. Congratulations. So we've got, now we're coming around to our final two presentations. Of room for questions at the end. So the next presenter is Gemma Marshall, and she's going to also be somebody who's had Tammy involved with her research, and as well as Russ Callahan. So over to you, Gemma.
I just wanted to start my presentation by asking everyone to think about the number of times they have heard about the opioid epidemic in recent years, whether it maybe has affected you, someone you care for, or someone that you don't know. As a follow-up, I want you to think about the number of times you have heard about the recent legalization of recreational cannabis. Do you know of any recreational users? Do you know why they might use cannabis? And lastly, have you ever thought or heard that cannabis could be used as a substitute for opioids? Hi, my name is Gemma. I am a biomedical student in my 4th year here at UNBC, and my supervisors were Dr. Russell Callahan and Dr. Tammy Claassen-Ross. And today I'll be presenting on the recreational cannabis legalization in Canada and the effects on monthly opioid-related deaths. How do I? So just starting off with a little bit of background information, the opioid epidemic continues to be one of the worst public health crises experienced in North America. However, this study is only looking at Canada. Moreover, from January to June 2021, approximately 86% of accidental apparent stimulant toxicity deaths involved an opioid. Research regarding the use of medical cannabis is plentiful. However, evidence regarding the efficacy of recreational cannabis use is sparse. As some of you may know, cannabis has been found to have potential medicinal uses and may be a suitable substitute for opioids. As a result, governments are increasingly leaning towards recreational cannabis legalization in an attempt to address the opioid epidemic. So using cannabis as a substitute for opioids may effectively reduce monthly opioid-related deaths. So you may be wondering what I specifically investigated for my research and why. Well, my research question was, is there an association between recreational cannabis legalization in Canada and monthly opioid-related deaths? Why this is important to me, I chose to do this research because the opioid epidemic is a prominent problem here in Northern BC. And I have been an advocate for harm reduction and treatment since I was a teenager, and because research in addiction, opioids, and alcohol hits close to home for me. So just quickly on the methods I used for this research, there were two phases of the methods of my research. First, I conducted a systematic search to identify any relevant literature. And second, an interrupted time series analysis was run using the data collected from the Statistics Canada Canadian Vital Statistics Death Database, or the CVSD. The CVSD is a survey that collects demographic information and causes of death annually and monthly from provincial and territorial vital statistics registries in Canada. The survey data had a 10-year span from 2010 to 2020 and uses the International Statistical Classification of Diseases and Related Health Problems, or the ICD coding system. And specifically, this data set uses the ICD-10 coding system. The data was grouped into specific ICD-10 codes related to any drug poisonings that resulted in a mortality. So for the time series analysis, male and female drug-related poisonings were separated, and the time series function of ARIMA was then modeled for both male and female pre-intervention objects. One of the most important steps when conducting a time series analysis is the step function, which for my research was performed on the combined pre and post-intervention data on both males and females. The step function allows us to determine if there is a statistical association between the legalization of recreational cannabis in Canada and monthly opioid-related deaths. It also allows us to determine whether there is an immediate or permanent shift in our series after the event of legalization, which allows us to see the difference between pre and post-legalization. So for females, the CVSD data series included a total of 12,195 monthly opioid-related deaths across a 10-year span, with 10,595 of those deaths coming from pre-legalization and 1,600 coming from post-legalization. So the formal date of recreational cannabis legalization in Canada was October 17th, 2018, which you can see is the red line represented on the graph. The modeled female monthly opioid-related deaths represented by the purple line shows the predicted deaths determined by the data analysis of the time series models. And then the black dots represent the actual number of monthly opioid-related deaths recorded by the CVSD. So in addition, the irregular sawtooth pattern seen on the graph represents the changing amount of monthly opioid-related deaths within Canada. However, there is no relation between cannabis legalization and post-legalization trends. So for males, the CVSD data series included a total of 22,560 monthly opioid-related deaths across the 10-year span, with 19,305 of those deaths coming from pre-legalization and 3,255 coming from post-legalization. And this graph aligns much like the previously seen graph for the females, in that there is, again, no relation between cannabis legalization and post-legalization trends. So what about the step function effect? Well, in order to be considered statistically significant at the 95% confidence level, the p-value must fall under the value of 0.05. As this table demonstrates, the p-value for females and males were 0.14 and 0.72 respectively. In addition, both the male and female ARIMA time series showed no significant step function effect on the association between recreational cannabis legalization in Canada and monthly opioid-related deaths. Therefore, there was no significant shift in our series after legalization, and there was no significant difference between pre and post-legalization. So this study also has several limitations. The amount of post-legalization data points from the CVSD data is significantly less than that of pre-legalization. Furthermore, the CVSD uses national data that cannot be separated into province or territory. This is an issue because provinces such as British Columbia and Alberta have higher opioid-related deaths than the rest of the country. So we also need to consider access to recreational dispensaries throughout provinces and territories, as some provinces had larger dispensary rollouts than others, especially those that followed private dispensary models. And lastly, the validity of the ICD-10 coding system must be considered as the system works to group any opioid-related deaths into different codes. So therefore, codes may be too specific or too generalized to catch all opioid-related deaths in Canada. So where does research go from here? Well, considering the previously listed limitations, there are many paths for future research to follow. Having data sets with more post-legalization data would allow for future research to run similar studies, but with longer post-legalization periods to allow for consideration of delayed effects. In addition, future research on this topic may want to use a more specific data set that allows for the separation of provinces and territories to better examine places with higher rates of opioid-related deaths. Moreover, future research should investigate the effects of accessibility to recreational cannabis dispensaries on opioid-related deaths. And lastly, there is a need for the examination of the efficacy of the ICD-10 coding system on opioid-related deaths to determine if there's a more efficient way of accounting for all opioid-related deaths. And lastly, I just wanted to say a big thank you to my supervisors, Russell and Tammy. It was really wonderful getting to work personally with them throughout the year. And I also wanted to say thank you to the UMBC Research Data Center, specifically Lorraine Sluggett. I would have never understood anything about a step function if it wasn't for her. And then lastly, I'd like to thank Dr. Trina Fife for holding my hand during all 5 of my search strategies.
Impressive. I'm so appreciative of the quality of these presentations and the fact that everybody's right on time, which is really appreciated. So I'm really glad. Thanks so much for this presentation, and I'm going to hand back to Tammy to say a couple of words for a second honors.
Thank you, Margot. Gemma, I just wanted to, Russ couldn't be here today, so I just wanted to pass on some of his thoughts. He wanted me to let you know that he thought you did extremely well throughout your honors, and he's sorry he couldn't be here today. I also want to echo that in that I think you did really well with this project, and I definitely look forward to seeing where you're going to go from here and where this research might go from here as well.
Thank you.
Yeah, it's so neat to see the RDC being used as well. So congratulations on that, Gemma. I'm really encouraged by the ways that people are connecting with the supports across campus for health research for students. So congratulations, Gemma. We're now coming to our final presentation, and then with some time for some questions to our panelists, and it's my pleasure to introduce Jonathan Doyong, who has been conducting his honours with myself and Jessie King. I'm going to keep my moderator hat on and call on Jessie to say a couple of words afterwards. But Jonathan, we're really looking forward to this chance to share your presentation with this crowd. So over to you to share your screen.
Thank you very much. That was a very good pronunciation of my last name. All righty. So you can all hear me okay, I'm assuming. I just want to say it's really, really great to be here, first of all, and it's really, really fun to see my friends from the senior seminar course, see how the research has progressed. Aiden, we recently connected, well, was not recently, but in 302 last year. So it's really, really fun to see you again as well. So my name is Jonathan Doyle. I'll be graduating pretty soon here with a Bachelor's of Health Sciences. And I decided to major in biomedical studies. And the title for this presentation is Learning to Bridge Knowledge Systems, Insights from a Scoping Review of Indicators in Indigenous Community Contexts. And my two supervisors were Dr. Margot Parks with the School of Health Sciences in the Northern Medical Program, and Dr. Jessie King from the Department of First Nation Studies. And I just want to, before moving on, acknowledge the both of you and say a huge thank you for being incredible mentors, for being patient, kind, funny, only making me cry a few times. It's just been an incredible journey, and you've changed my life for the better. So to run through the outline, I'm going to start off by positioning myself as a learner, give you all a very brief background of who I am, and then we'll dive into the rationale behind the project and the research question itself. Following this, I'll share with you two important methodological influences that shaped how I conducted this work, and then dive into some of the more interesting findings and key insights. And then we'll end with concluding remarks followed by questions. So I'm a non-Indigenous student. I'm a settler Canadian. I got a little bit of a French and Italian in my blood. My father, he came here from Quebec in '86 to pursue becoming an elementary school teacher. Mom was born here, but my nono and nonna, her parents, they moved down in the late '50s. So I was born on unceded Lheidli territory, and I've been privileged to live here and grow up for my entire life. And I would like to acknowledge that I am a visitor on these lands, and that is something that I did not know for the majority of my life, which kind of brings me to my point and sort of the overarching reason that I decided to pursue this project at all. So I actually initially met Dr. King last year during First Nations 302, and this experience in itself was incredibly profound in the sense that it shed a lot of light on colonialism, on the consequences and ramifications that it has on Indigenous community members, and it did so in a way that I felt like I would have never been able to conceive on my own, especially because I come from a Western background. I'm surrounded by Western dialogue. And I've realized rather quickly, especially as someone who's hoping to work in healthcare one day, and especially in the North, Prince George, that I should better educate myself and dive into more of these conversations and learning experiences. And despite there being a lot to learn about our history, about these contemporary manifestations of colonialism and its relationship to health and well-being, this is really just the beginning. I see this as a stepping stone to a much larger and more meaningful learning journey. And the last point of these few slides, I just want to share how I just hear some echo. Is everything okay? Oh, are people frozen or?
I think there is one microphone open, which is the HRI speaker. So we might be able to get somebody to just mute the microphone in the front because it is creating a wee bit of an echo.
All right, no worries. I just wanted to make sure. So this last point, as I was saying, it's not confined to this project. I think it's fundamental to how I'm trying to orient my life and how I'm striving to do everything as a friend, as a caring friend who's in full support and wanting to see the full breadth of Indigenous sovereignty, ownership over their lives, knowledges and research, and of governance over their communities as they see fit. So with the rationale behind this, there's a few key reasons why I think it's important. The first one is that there's an overwhelming amount of literature that suggests that we are now, humans are now the dominant driving force that's impacting the actual functioning of the Earth system. And many scholars consider that we now live in the age of the Anthropocene. And the rapid acceleration and intensity of global environmental change and degradation places great demands on humanity to develop innovative ways and processes for connecting knowledge systems that are conducive to sustainability and recognize the deep reciprocal relationships between interacting social, ecological, and cultural systems. And I want to point out too that the way that we define or measure well-being in terms of indicators matters a great deal. It drives government policy, it contributes to shaping our societal values, our knowledge pathways, and this is especially relevant to how we interpret and respond to climate change and resource extraction, which have profound consequences for Northern and Indigenous communities. A lot of the indicators, many indicator sets seem to use a comparative and perhaps competitive way of tracking progress that largely seems to stem from colonial dialogue as well. And what I found is that indicators pertaining to Indigenous communities are often interpreted through a deficit-based lens of inherent lack, whereby the focus is on statistics that perpetuate disadvantaged and harmful stereotyping. Now, along with that, the logic behind many indicators is criticized as being a little bit too reductionist in the sense that they just reduce the complexity of how we conceive well-being, right? And they focus more on materialist and sort of technocratic elements, and that ends up providing a convenient display of quantitative factors. And these quantitative factors seem to be seen with some sort of objective truth, right? But it's important to note that indicators represent only the components that their designers choose to measure. And this poses significant barriers to any meaningful inclusion of Indigenous worldviews and because of their reliance on a lot of intangible elements, things like spirituality and culture and connection to land. And these do not readily lend themselves to quantification. And because of this, because their value is difficult to numerically ascertain, governance structures can claim that it's difficult to justify any source of resource allocation or policy change. So more innovative approaches are needed. And this photo that you see on the left of the screen, this was made by Annika Chiazon. She is an absolutely incredible artist, part of the Echo Network. And she drew this while the Echo Network was hosting the Pulse series. More specifically, it was during the Healing Indicators session where we had a lot of wonderful speakers. And the cool thing was that she actually drew this live time while the guest speakers were doing their bit. But it's important to note because this session in particular seemed to enlighten the path for my research. And the speakers really emphasized how Indigenous communities and folks were championing this sort of more forward-thinking transdisciplinary work. So the research question that I came up with here is, what is the scope of published literature that addresses quantitative and qualitative approaches to health indicators used within Indigenous community contexts? And the first methodological influence I would like to talk about is two-eyed seeing. And I first came across this during FNST 302 with Dr. King. And it's a concept that I believe was initially developed by the teachings of Charles Labrador, but then introduced and more expanded upon by Albert and Moderna Marshall. And to quote Iwama et al., two-eyed seeing is learning to see from one eye with the strengths of Indigenous knowledges and ways of knowing, and from the other eye with the strengths of Western knowledges and ways of knowing, and bringing both eyes mindfully together for the benefit of all. And so it really fosters this sense of togetherness in quite a beautiful way. Now, the second one that I'd like to mention is ecosocial approaches to health. Now, ecosocial approaches to health, this I came across as being a research assistant with ECHO, as reading a lot of Dr. Parks's work. And it's quite a dynamic term that seems to encompass and underscore the reciprocity among ecological and social determinants. And a key takeaway is that the lands are ecosystems. They are not outside of the economy or society. They are not some driver to be accounted for when convenient, but instead they're actually part of the very foundation that sustains life. So for the methodology and research design, I did a scoping review. I thought it was more appropriate than doing a systematic review, which would take more time for, there's a strict limit of time with the honors thesis project, and you normally need a bigger team to do it successfully. And the other thing as well is that it can be used as sort of a preliminary step to a systematic review. And this work can therefore serve as some sort of foundational project upon which I hope to build and continue throughout my graduate studies. Which will be the case when September comes around. And I followed Arksey and O'Malley's framework and took into consideration Levac's recommendations. And I want to take this time to also just express many thanks to the librarians for creating time to help me out. It was incredibly beneficial. I used 4 principal databases and then incorporated Google Scholar just to see if there was anything else that I could rip off, any good finds. And I ended up with 17 studies, which was pretty good. I also want to mention that I used Distiller SR to help conduct this review, and that also helped generate the Prisma diagram. And I would like to thank Katie Cornish because she was very generous with her time and she helped me through every single step along the way. So with regards to the findings, one of the really interesting things that came from this review was that I found more specific detailed frameworks that addressed how Indigenous communities were pursuing their ambitions of creating health and well-being indicators. And because of the time constraints of this presentation, I won't go into every single one into detail, but these 7 stood out in particular because they emphasized mechanisms that sought to bridge different kinds of knowledge systems. And if we take a quick look at column C, the overwhelming majority used both quantitative and qualitative data. And a lot of times when studies implemented a quantitative lens, they were using technical, hydrological, archaeological, and other biophysical data pertaining to things like shellfish biomass, beach elevation, sediment characteristics, and so forth. On the other hand, nearly every single time that qualitative approaches were used, it was in the form of workshops and constructed mini interviews or questionnaires. And participants were given questions, oftentimes open-ended questions such as, what does health mean to you? And how do you think your community is doing? And these questions were able to gather information on physical and non-physical health priorities, on community health and well-being considerations, and on the potential impacts of well-being if lands and natural resources are damaged or destroyed. And I just want to point out that I don't have enough time, I think, to go through column D, but if you can't think of a question, I'd be happy to elaborate on that, because that's just in consideration with studies being a top-down, bottom-up, or a mix of both. Before moving on, though, I do want to emphasize something. And the biocultural approach, as you can see, there were 6 studies in particular that seem to really appreciate this approach. And it's unique in that it first acknowledges social ecological systems and these sorts of fundamental interlinkages between humans and nature. And these SES approaches have gained quite a bit of traction in terms of sustainability and conservation discourse because they can highlight trends and patterns that are not apparent with single disciplinary approaches. But these SES approaches have been criticized by some of the authors for neglecting more of the nuanced and perhaps intangible components that mediate these human nature interactions, right? And that's where culture becomes relevant. So it does a really good job of integrating mechanisms between social, ecological, and cultural systems. And from these findings and studies, I was able to take away 5 key insights. And I want to be really, really clear that I did not come up with these insights on my own. They didn't flare from my own subjective interpretation of what the literature was saying. I drew these insights directly from authors, and I chose these 5 in particular because they seemed like really wonderful sort of overarching inputs that were quite consistent among the majority of studies. The first one in the middle that you can see is connection to place. And it's at the crux of everything, and it acknowledges the connections between humans, non-humans, and the landscapes, and the many ways that the environment impacts our everyday lives. The second one is that combining different knowledge systems has the potential to benefit everyone. And we're becoming more and more aware that together, local, indigenous, and Western worldviews can greatly enhance our understanding of how to care for and strengthen the role of biodiversity and ecosystems. And it can also broaden our understanding of the spectrum of health and well-being. The third insight is to create collaborative spaces that are equity-driven. It's important to bring together knowledge systems in a mutually respectful and transparent way. When it comes to a lot of health indicators and assessment modes, it's crucial that each component of the research process, including every single decision, action, and communication, is conducted in a space where non-Indigenous and Indigenous voices have an equal say. However, this sort of phenomenon of having an equal say, of having that equal playing field, it can be tricky, especially when we try to merge different knowledge systems together. So the next key insight then is to acknowledge power imbalances and predetermined external validators. What I've come to understand is that different forms of knowledges, such as the natural sciences and more locally based knowledge traditional systems, can certainly have similarities, but there are important aspects of each that cannot be fully translated into one another, and nor should they, because they're unique in their respective ways. But oftentimes, even unintentionally, we engage in a one-way process where, when wanting to integrate knowledge systems, Western scientific approaches ends up being some sort of external validator because of the sort of colonial system in which we are embedded in. And when that happens, we can exclude a lot of legitimate and valuable information from Indigenous ways of knowing.
Jonathan, as you go to the next slide, I'm going to have to mention that you're up for time, so
Okay.
we'll let you wrap up now.
Okay, sounds good. I'll move on then to this last point has to do with the top up, bottom up anyway. So I'll move on now to my concluding thoughts. But I want to share that indicators, they are designed as tools to aid in providing a more comprehensive community health assessment. Yet they can never fully express the depth or magnitude of the intangible values and connections between humans, between the environments, and between the spiritual worlds. And the successful implementation of indicators may depend more on how and in what context data are collected than on the actual specifics of the indicators and the metric themselves. Everything is based on the quality of the relationships that you're nurturing. And it's crucial that regardless of whether we are trying to nurture relationships between knowledge systems, worldviews, or societal sectors, we enter the space with humility, open ears, and a caring heart. And I'll end it there so that we have time for questions. But thank you very much for listening. I appreciate it.
Congratulations, Jonathan. It's so great to see this presentation in this context, and I'm really happy to hand over to Jessie to put on her supervisor hat and offer some remarks.
Wonderful, thank you. Hello, everyone. Jonathan, what a pleasure to see where you've come from and where you're at today. And I love that you mentioned that we made you laugh and cry a lot. You just about had me crying at the beginning of your presentation. It's been an incredible journey to witness what you've been going through in the last almost 16 months now that I've had the chance and the opportunity to know you, and the work that you're doing here. It's only the beginning, and I love the way that you were so meticulous in picking your topic and having your indicators, your decision making, and it's been just such a beautiful experience to watch your eyes being opened more and more and to see the possibilities that lay ahead of you. So, and Doyong, thank you. I hold my hands up to you and the work that you've done. And I want to express my gratitude for Margot being there when I didn't know where to go. When you gave me that question of where do I go for an honors thesis? Well, I just happened to have seen Margot Parks in the hallway. I'm going to ask her. So I feel like, Margot, I want to extend my gratitude to you as well equally. Jonathan, well done. Thank you.
Yeah, congratulations, Jonathan. One of the many features of your work here is, as with a lot of these presentations, that it's fueled a broader collaboration, and the work and the conversations and discussions from your honours thesis has fed into our Eco Network team, and as well as fueled Jessie and my collaboration and sense of connections, and also the other colleagues, undergraduate and graduate colleagues, across several provincial and national teams. So I think it's a really nice way, just given that I think all of the presentations have exemplified that. I think we now we'll get Hayley. You can turn on your camera again. We're bringing our panelists into our imagination again. I'd really like to open. We do have a general question in the chat box from one of the audience members, but I'm just going to hold, and that question, I'm just going to mention it in the background because it might be something that each of you ponder in the background. So Bruce asks, if I may ask a question, what was your biggest challenge in doing your research? So I'm going to get you to think a little bit about that, because it's as honours students, you're right at the beginning of that trainee research experience, and it's so helpful for people to not just hear about your successes, but your challenges and how you've, and even in this time frame, been able to overcome them. So that's one question, and if anybody has any other specific questions to any of the panelists, we'd also be happy to come to them. But I am going to ask, I'm just going to go around the table and ask if each of the speakers would tackle that big picture question, and we'll look at, because I have my question was sort of along those lines. Have I missed any other questions in the chat box? I don't think so. So around to you, Lindsay. You may need to come up to the front of the so that we can see and hear you. You might need to come up to the front of the room again. Welcome back. Thanks, Lindsay.
So am I just answering what my biggest challenge was, or were there other questions?
Yes, that's right. Yep, you're answering what your biggest challenge was, and I'm not seeing any other questions coming up just yet.
I felt like just about everything was equally challenging. Like I started out in May of last year, and I'm like, okay, I'm going to learn how to do a literature review. And then it was learning how to put together a research proposal for ethics. And then, you know, a few months of waiting for that approval, and then learning how to do a thematic analysis of literature recommendations, which was sort of my practice role. And then learning how to interview participants, and learning how to transcribe with taking slightly less than hours and hours. And then doing more in-depth analysis, and now writing the paper. It's all, I guess, because Caroline has helped me build my skills stepwise, like one step at a time. Each thing feels equally challenging, but probably the hardest part was working with all the data and trying to figure out how to make this wealth of information that all these participants have given me. Like there was so much more than what I could share in 10 minutes, but just finding a way to do justice to that, I think, was the biggest challenge. And it's something Caroline and I are going to continue to work on.
Yeah, that's a great, I really appreciate you taking us through that, the range of your learning experiences again, Lindsay. It's very impressive to me that you're able to achieve all of that in an honours thesis, and leaning into a mini master's probably. So, but congratulations on being able to achieve even learning just that is and overcoming those challenges, or at least pushing through them, is really impressive. So Aiden, I'm still keeping an eye out for any other burning questions. I can't see if there's any questions in the room. So Leanna, if you could pipe up and let me know that in the chat box, that'd be helpful. But Aiden, your thoughts on big challenges?
Yeah, so some of the biggest challenges, I think, for me were working within timelines, especially with the MyTax grants. Working on, I was like, okay, we're going to have this done by this date, and we'll move on to this. And I was originally going to do interviews with people at Northern in the communications department, and that obviously did not happen, and that will be someone else's project. But kind of learning the process and the real world, I think we see a lot of research produced, but we don't necessarily see behind that curtain of the struggles of timelines or setbacks or things like that. So kind of, yeah, lowering and really learning how to kind of be flexible. And yeah, that was my biggest takeaway with that and biggest challenge, I think. Originally, when we brought the project forward, I wanted to focus on vaccines and communicating around vaccines. And we've changed it so many times since then. I have about 3 iterations of a research proposal before the one I submitted. Yeah, so yeah, really that. And then just kind of, mine's very interdisciplinary. So Kafui and Aaron didn't know each other before we did this project, and kind of bringing everyone together was challenging, but really rewarding in the end. Thank you.
That's great. I'm aware that Bruce is interested in doing his own honours thesis, so you're getting some great tips here, Bruce. And that flexibility and the changing tax, I saw Kafui laughing. That's the laughter of recognition. So research is really that word these cycles of needing to go through changes is such an important lesson. So thanks for highlighting that, Aiden. We'll come around to you, Haley. Oh, sorry, go ahead.
Oh, good. That was it. I just. Sorry there. We'll come around to you, Haley. I can't see what's happening in the room, so I'm sorry if I'm being clunky here.
It's all good. I'd say flexibility. I agree with Aiden. It's a good skill to learn throughout your honors, moving on to your postgraduate studies, whatever. Learning how to be flexible and kind of just roll with the punches is definitely a big takeaway from this. I think one of my biggest challenges with the scoping review was just the limited amount of research that was available. So then in order to put together the scoping review, I was trying to find articles that were relevant to the topics, but then also were relevant to a rural and remote setting, even though they weren't specifically looking at rural and remote settings, and kind of finding ways to incorporate all of that to address the research question, to find what there is, because there really wasn't that much. So I'd say that was probably my biggest challenge.
Yeah, it's a great challenge, Haley, and it actually, it's just a little flag for Leanna in the future. I actually feel like we probably need to bring together an HRI seminar on the challenges of doing literature searches in rural and remote contexts, because so many different topics have that same challenge. And if we could just pull all the lessons from we've hit that challenge so many times. So thanks for underscoring that, Haley. That might be a really interesting little brainstorming session to have with the HRI at some point. So Gemma, we'll come to you and then round to Jonathan.
Yeah, I would say probably there was 2 points that were really challenging, and the first was before I had even started any research. I just the thought of doing an honors is so overwhelming that you're like, oh, well, where do I start? Well, there's so many things that I could do. And then thankfully Russell was just like, oh, well, I have this project that you could do. And I was like, okay. And then I would say the second most challenging part was probably looking at the statistics for it, because my experience in our commander is about as much as Stats 240 will give you. So that's where Lorraine was really helpful. But yeah, it took me a long time to write my results, because I just was like, well, I don't even understand any of the our commander stuff that you've sent me. So yeah, that would be about.
Well, that's impressive. That's some really steep learning curves there. And I think, Gemma, the fact that you were able to master them and speak so coherently about what you'd learned, and from somebody that a lot of this was new to, is very impressive to me. So congratulations. And Jonathan, of course you had no challenges because your supervisors removed them all. No. We'll come to you to a final word on challenges before we wrap up the session today.
Yeah, you stole my answer, Margot. Yeah, that's a really good question. And my brain kind of flies out in multiple different avenues when I think about this entire experience. The whole thing was a really, really big learning curve. If I were to redo it now, there's so many things that I could pinpoint that I would do differently. I think the first thing that's challenging is when you're working with these incredibly sort of broad interacting systems, it can feel really, really difficult to sort of pinpoint what you're going to study, right? When you talk about the environment, when you talk about health, when you talk about social systems, political systems, and how they all interact, it's pretty complicated. And I think because I feel like I'm sort of entering this landscape, I was a little bit overwhelmed initially. And I think Margot and Jesse did a good job of just pinging me back into place whenever I kind of fly out another direction. So that was the first thing, but I did really, really enjoy that though. I think the second thing is learning how to do a scoping review, learning what keywords are you going to use when you do those database searches. I have so many different variations of words. Now that I was looking at all my old ones and I was like, oh my, just trying to find the perfect amount of studies, or at least just trying to find, it was a little bit challenging. And then after that, learning to analyze studies in a way where you're actually able to synthesize and integrate the information in a really coherent manner. I noticed when I was writing my discussion that I would like to improve on that moving forward. But I couldn't have asked for a better experience. It was filled with a lot of challenges, but just amazing.
Well, challenges are in the spirit of research, it's often the challenges that give you the most learning. So I'm so impressed with all of your reflections. Going back to Lindsay, Aiden, Haley, Gemma, and Jonathan, Tammy had to step off to another meeting, but she wanted me to pass on that it was a pleasure to have met you all in the grad seminar. And so she's so proud of how far you've come. And as a collective, I'm so sure she's really interested in seeing just what can come from an intensive burst of effort and talent. So this is the kind of session that makes UNBC feel really proud of its graduates. The HRI seminar is very honoured to profile this session, and at 4 o'clock, after an amazing hour and a half, I want to say a huge thank you to you all. Big thanks also to the HRI team, Leanna and Lisa and Katie and Alex and the whole team who enable our seminar series to happen. I cannot underscore strongly enough how much I encourage you all to come to the HRI seminar series. The honours students presentations are always amazing, but so are every seminar. So to be blunt, we just don't get the kind of attendance that we would like to. So that's a prod to all of you. You're missing out if you're not. But you can also go back to the recordings, and that was 5 really interesting recordings that we have there. So one of the things we sometimes do when we put up the honours is just to say the timestamp when each recording starts, so that people can scroll to the next presenter. So we'll try to remember to do that, Leanna and Lisa, so that we can have each of the presentations that people can find the topics easily. Huge congrats coming through in the chat box. Thanks everybody. I really appreciate your time, and we can call our HRI seminar series a wrap for this academic year. And we'll look forward to, I think we have a certain Jessie King and a Kafui on our list for future presentations. So the seminar series is going to be filled with talent as we come back next year. Thanks everybody. Really appreciate all of your effort. Take care. Bye.
Bye.
Thanks for the great question, Bruce.